Come on down. All right, I think we're ready to roll here. So you can see we have people still arriving into online. So there's 23 people and people in the audience. So very excited to have Jenny Shin, one of our own, giving us pulmonary grand rounds today. Jenny has been with Yale for the last 10 years. First as a resident at Bridgeport Hospital and then a fellow in allergy immunology, and is now an assistant professor in the allergy and clinical immunology division here at Yale. So did her PhD work in microbiology and immunology in New York Medical College. And here, I think during fellowship and worked with Insoo Kang on the various immunologic studies and has published extensively. I think that we're very excited to hear her talk today about pulmonary manifestations of primary immunodeficiency disorders. And I want to say that I think that this is a growing field and that Jenny's been at the cutting edge of it. And I think one of the big discoveries that she has made over the last few years early on has been the relationship between immunodeficiency and severity of COVID, which she published during the pandemic and really was able to take advantage of the pandemic, which was a challenging time for all of us, but actually make significant contributions to our field. So excited to hear about this. I think it's an incredibly important topic in airway disease, but all lung diseases, because it turns out that immunodeficiency is incredibly important with how we handle things in the lungs. So welcome and look forward to your talk.
Thank you so much, Dr. Chuck, for the kind introduction and the invitation. So today, I want to discuss about the clinical manifestations of primary immunodeficiency disorders. And I also want to focus on pulmonary manifestations in PID. And lastly, I want to discuss about multidisciplinary approach for diagnosing and managing these patients. And so agammaglobulinemia is actually the first PID diagnosis made by Dr. Bruton back in 1950s. So as you can see here, he found a patient with no gamma globulin in the serum compared to healthy controls who had gamma globulin. And he also discovered way of giving immunoglobulins as a therapy to treat these patients. So after giving subcutaneous injection of immunoglobulins, he found that the patient had increased level of immunoglobulins in the serum, and it was helpful for the patient to protect them from infections, especially pulmonary infections. Then in 1971, you guys probably know about David Bader. He's the boy who was born and immediately was placed in the bubble. So in the picture, we have Dr. Scheer, who was the immunologist for him, and they knew they had to do this because he had an older brother who died at a very early age due to infection, and brother also had X-linked SCID. So he was got bone marrow transplant from his sister, but unfortunately he had EBV-driven lymphoma and died in 1984. So since then, we found many genetic mutations that are related to inborn errors of immunity. So these are only like most commonly known genes that are listed here. And what this International Union of Immunology Society did is that they grouped them into different categories based on the function of the genes and the clinical presentation of the patients. So as you can see here, the predominantly antibody deficiency has the biggest number of the genes. And also, you know, this is the most common immunodeficiency among all the inborn errors of immunity. And this more recent paper in JACI shows initial presentation of IEI of 16,486 patients, they had it. And you can see 70% of patients, the majority of patients are only show coming with infection. And this is usually pulmonary infection without any immune dysregulation symptoms. But there are 9% who only present with dysregulation without infection. There are 9% with infection and dysregulation, and there are people with other symptoms. So these are not directly related to immune system. Symptoms such as fatigue or failure to drive or endocrinological disorders. And then 1.6% has only family history of inborn errors of immunity, and 3.3% had only lab abnormalities. And in the same paper, they divided these 16,486 patients into different categories of IEI, and they looked at what was their presenting symptoms. And as you can see here, the CVID, common variable immunodeficiency, and most of the predominant antibody deficiency patients, like 80% of them had infection-only presentation. But interestingly, disease with immune dysregulation, they obviously had more of the dysregulation symptoms without infection, and the combined immunodeficiency with associated or syndromic features had more of these other symptoms. So altogether, I think we know the infection and infection-related manifestations such as bronchiectasis is the most common clinical manifestations of inborn errors of immunity. But we really cannot ignore the rest of non-infectious manifestations. And many of them are actually pulmonary manifestations, if you see here. And that's because these non-infectious complications are more dangerous. This is old study, but it clearly shows that when they looked at CVID patients, CVID without non-infectious complications had much higher survival, and CVID with non-infectious complication has much higher poor survivor. So when we see patients with infectious complication, we are less concerned because we know somehow we can fix them. But when they come with non-infectious complication, that's when we really have to be careful about monitoring their symptoms and treating them. So now we're gonna focus more on pulmonary manifestations. So I just group all the primary immunodeficiency based on their functions and divide them into pulmonary infection and non-infectious complications. So non-infectious complications are pretty much overlaps among all the immune defects. Most common ones are bronchiectasis, asthma, and ILD is big one, and GERD. And lymphoma and autoimmune related all kind of pulmonary manifestations. But if you look at the pulmonary infection part, you can see some uniqueness of the infection, the pathogens that are causing infection in different immune arms. So humoral immune defect, we know it's encapsulated bacteria and atypical organisms. And cellular immunity defect, we'll worry more about viral infection. And combined immune defect, we'll more about, worry about the opportunistic infection. And complements are very similar to humoral immune defects that they are more related to encapsulated organism, and phagocytes disorders are the most scary ones that we often see, necrotizing pneumonia, lung abscess, and empyema. So for us, it's very important what's causing the infection. So we really value your cultures, especially BAL. That's been always great sign, give us clue which immune defect might we have to hunt down. So when we see these patients with both infectious and non-infectious manifestations, the way we evaluate the patient is our labs. And fortunately, Yale has great labs that we can order: immunoglobulin levels, vaccine titer, flow cytometry. And if we worry about T cells, we often do lymphocyte proliferation assay. And if we worry about immune dysregulation, sometimes cytokine panel can be helpful. And DHR is always helpful if we worry about some phagocytic disorder. And image studies are always very important for us. And at the bottom line, we've been doing lots of genetic testings to really find out what's the monogenetic or polygenetic mutation that is causing this clinical presentation of our patients. So I'm gonna give you some examples of our patients that how we evaluate and how we treated these patients. So this is 42-year-old female whose initial presentation was chronic cough, recurrent bronchitis, and had 2 episodes of pneumonia in the past, and was recently diagnosed with ILD, and has a history of ITP and splenomegaly when she was very young. But she had a unique family history that her mother has RA, and the maternal grandmother was always known as always ill. So we did our blood work. So it shows that patient had low IgG, low IgA and M, and the ammonia vaccine titer was very low, and B cell was low, and switched to memory, B cell was almost undetectable. So she is a very typical presentation of common variable immunodeficiency. And so we did invite IEI panel for genetic testing, and we found the pathogenic variant for NF-kappa beta 1, which is also very well-known gene mutation for CVID. So in this case, like everything fit really well, and we got the genetic diagnosis as well. So we managed her with IgG replacement and monitored all these complications that come with this NF-kappa beta 1 mutation, which are ILD, splenomegaly, thrombocytopenia. And one major thing is this gene mutation is associated with lymphoma as well. So she had a genetic counseling for the risk of lymphoma, and her children's were tested as well. So in general, she's pretty well managed, and patient is pretty happy with the current diagnosis and the management, and we pretty much help the patient, and it's one of the more of the satisfying story. However, there is also another story of 47-year-old female whose initial presentation was only about joint pain, joint swelling, and skin rash. So initially, she was seen by rheumatology, and they did all the workup, and they diagnosed her with seronegative inflammatory arthritis, and they treat her with different kind of immunosuppressive therapies, but none of them worked. So they sent the patient to us for evaluation of acquired angioedema because she also has some swelling. And as a part of the workup for acquired angioedema, we checked immunoglobulins because to rule out lymphoma. But this was what we found. So she had a very low IgG, IgA, and very high IgM, and basically not responded to vaccine at all. And CD19, the B cell was very low and almost no switched memory B cells. But she never complained about infection, recurrent, sinopulmonary infection. So as a baseline, we did CT checks because now people with true CVID as a baseline, we do CT chest and abdominal ultrasound to rule out splenomegaly and any kind of lung manifestations. And surprisingly, like she had multifocal bronchiectasis, numerous discrete solid nodules, and one of the nodule was 7 millimeters. So we referred to PERM, and patient had bronch, and AFB was positive for mycobacterium. So this was a big surprise for the patient because she always felt well. She never thought she had pulmonary infection, but it was a surprise for her. And with all this going on, we did a genetic whole exome sequencing in this case and found a mutation on PRC gamma 2. This was a novel mutation, so it came back as a VUS. But looking at the mutation, this is a frame shift, so most likely it's gonna be pathogenic. So PRC gamma 2 is very important for B cell survival and proliferation. So what happens is when BCR, the B cell receptor gets activated, PRC gamma 2 gets activated, and it will activate DAG and IP3, and DAG will phosphorate ERK and JNK, junk, and IP3 will increase the calcium influx, and through the downstream, it will activate B cells for survival and proliferation. So But since it's a novel mutation, we collaborated with NIH, Dr. Ombrero at NIH, who has expertise in studying PRC-gamma2. So he studied our mutation. So as you can see on the top graph, our mutation is in black. So basically, the cells with our mutation was not able to increase any calcium influx and also was not able to do any ERK phosphorylation. So basically, this research shows that our patient has loss of function for PRC-gamma2. So knowing that the patient has PRC-gamma2 loss of function was somewhat exciting for us that we made a diagnosis. But how are we gonna help this patient based on this mutation? Because PRC-gamma2 gain of function is associated with autoinflammation. So if patient had gain of function, then we can kind of explain the joint pain, joint swelling, and skin rash. Maybe it's autoinflammation process, and using all these biologics like anakinra and sirolimus might help, right? But she has loss of function, and we still use them, but none of them were very helpful. And we were just not fully able to help this patient's symptom. So one thought was that maybe it's the reactive arthritis from the MAC. So we treated the patient with triple therapy, but that was also not very helpful. And IVIG, her numbers became better, but she still felt the same. She's like, I never had the infection anyway. So she wasn't very happy with, IVIG, but, she knew she needed to be on it. And we even did the Lyme testing, and it was IgM Lyme immunoblood was positive. So she was treated for Lyme arthritis, but still she's, she always described as like, maybe I'm better from, 7 out of 10 to 4 out of 10, but never fully better. So this was actually an article that this patient published in New Yorker saying, we get excited when we make the diagnosis, but if we can't really help the patient based on the diagnosis, it's pretty sad. And she's always very appreciative for what we are doing, but inside of her, she's struggling. And I think we see this in many of our patients too. All right, so as a summary, humoral immune defect consists 60 to 70% of PID, and pulmonary infection are the most common, about 70% clinical presentation. And patients with non-infectious manifestations present with higher mortality. And non-infectious pulmonary manifestations are very widely variable. So, I mean, it's, any of them any of pulmonary manifestations might be associated with IEI. And managing non-infectious manifestations can be challenging. So next, I want to discuss about some of the multidisciplinary approach for diagnosing and managing these patients. I think I probably gave you a good impression about how we really need multidisciplinary approach because our patients are presenting with symptoms of all different organs of their body, right? We need, pulmonologists, and we need GI, we need all different disciplinary help to really diagnose and help these patients. And next, I want to focus more on role of genetic testing and role of in-depth immune profiling of these patients. So first, I want to show some of our data. So this was done by Samantha Nobari, who is an internal medicine PGY2 right now. So we had a question about VUS because I'm sure those who are sending out a lot of genetic testing, probably 95% of time the reports will say VUS. So we don't know what to do with it because it's not significant. So we just put in our drawer and don't bother thinking about it. But I always felt that those VUS probably have some value in it because sometimes when I compare VUS with our patients, there seems to be some relation. So what we did was we extracted all the patients' data from JDAT. So all the patients with 9 and 10 code for immunodeficiency. We collect them, and among all the New Haven health system, there were 10,820 patients. And we only looked at the patients who actually came to our AI clinic, which was 1601 patient. And from those, there were 102 patients who had genetic testing. But in here, I excluded the ones that had a pathogenic variant. I only included the ones that had a VUS. That was 1 or 2 patients. And then within those 1 or 2 patients, they did not just have one variant, right? They can have 5 different variants. So later on our analysis, we included all the variants. And some of them had whole exomes, most of them had invitae, and we manually extracted all the medical records, including demographics, medical history, and initial lab values, and results of genetic testing, and record them in REDCap and did the analysis. So when we first did the analysis, we first tried to group them into different categories. That's like what the IUIS did. So we did 2 different ways of grouping. One was unbiased way with UMAP project with K-mean clustering, which was done by Rayas Osmani, who is in rheumatology faculty. And then I did more of the manual clustering by looking at the function of each genes based on what's published in IUIS. So we were able to group them into 6 different clusters. And when we looked at the association between these clusters with their clinical manifestations, it was really interesting to see that there was some correlations. So especially the group that had a B-cell immune defects, they actually had the highest pneumonia percentage, and they had the highest pulmonary disease frequency, and they obviously were more on immunoglobulin replacement. So this is VUS, right? So people will not consider this as significant, but here, at least, B-cell immune-related gene VUS seems to be correlating with what's already known, that they are more prone to get pneumonia, pulmonary infection, and they need immunoglobulins. And next slide shows the heat map that, here I just want to point out that cluster 3 is the humoral immune defect, and they have the lowest IgG number. And interestingly, the T-cell immune defect, which is cluster 4, had the highest soluble IL-2 receptor level. And soluble IL-2 receptor is the T-cell activation marker. So maybe these patients with VUS on T-cell related genes might have overactivation of T-cells, which drive their symptoms. And another interesting finding was cluster 1 was autoinflammatory related genes, and everything is red, meaning like it's all overly expressed. So maybe the overexpression of all these immune cells and immunoglobulins, they might drive these patients to have their clinical manifestations. So role of the genetic test. So I think we all know that if we have a known pathogenic variant on our genetic report, we are happy, and we know we made a diagnosis, and we can treat the patient based on that genetic defect. But even when you see VUS, I think our data is giving us some clue that it should not be disregarded, and it may predict biomarkers for assessing immune dysfunction and or dysregulation and the clinical manifestations based on the known function of the genes. So this was exciting for us, that maybe VUS is something we continue to explore. So lastly, I want to show you the role of in-depth immune profiling. So for this, before I get into the case of the patient, I want to give you some background about 17q12 deletion syndrome, because our patient have this syndrome. So this is a heterozygous deletion of about 1.4 megabase spanning DNA on chromosome 17. And there are 15 known genes that have a deletion, and they are in the red box. And it's pretty novel syndrome. So the frequency is about 1 to 10,000, only known in Iceland. And inheritance is mostly de novo, and there are some autosomal dominants. And their clinical features are really very well known for their renal disease, renal cyst or agenesis, because the two genes that are deleted, which are the HNF1 beta and LHX1, those are related to kidney genesis. And they can have more of the like autism or schizophrenia or bipolar disorder. But obviously, our patient came to our clinic because even though he had all these clinical features that are consistent with 17q12 deletion syndrome, he had the most concerning problems that the mom had was his recurrent skin and upper respiratory infection that he's missing almost half of his school. And he also had a lot of allergies as well. And this is a picture when he was admitted to the hospital because he had really bad impetigo and along with upper respiratory infection that he was admitted and received IV antibiotics. So we worried about his immune function because he has recurrent infection, but we did all the basic labs that we usually do. None of them were positive. Everything was completely normal. Then I thought maybe like he needs a little bit more in-depth T cell profiling because his recurrent infection with some increased, allergy history. Maybe there is some dysregulation of T cells because as you know, Th1 is involved in intracellular pathogen defense and Th2 is involved in allergy symptoms. So he might have some dysregulation among his T cells. So we made a hypothesis that maybe they have T cell alteration in 17q12 deletion syndrome, and we decide to recruit these patients, get their medical history, and study their T cells. And if they do have a T cell defect or dysregulation, we want to figure out why they have them. So the recruitment was done through the foundations. This is a group of parents and the children who has the defect, and they have been very helpful. So the medical student, Alan, was able to work on this since 2022, and he used the Quadric to recruit the patients and collect all the medical and genetic data. So from 37 patients that we were able to recruit, gender was pretty evenly distributed. And the mode of inheritance was consistent with what's already known, that there were more of the de novo patient and there was some autosomal dominant patients. And age of onset was, mostly in a very early age since they usually get the diagnosis based on their kidney problems. And this is their genetic deleted regions. And so you can see that 37 patients have a variation where they have the deletions, but all of them had the region that contains those 15 known genes that were deleted. So Alan collected all the medical history, and we found that obviously they had 80% of them had kidney disease because that's the most commonly known manifestations. But, fairly high amount of patients had eczema, asthma, food allergies, the atopic disease, and bronchitis, ear infection, and, sinusitis and pneumonia, so sinopulmonary infections. And when we were collecting this data, it was really having more than 4 a year. So I took their PBMC, and then they shipped us the cells, the blood, and we isolated PBMC and stimulated with PMA, inomycin, and tried to stain for the cytokine secretion. And it was really interesting to see that these patients had significantly lower TNF-alpha and interferon gamma from CD4 T cells, but the other cytokines, IL-13, IL-17, IL-10, they were normal. They were like the same as healthy controls. So this can explain why they are getting so much infection. And Hyunjun, from the postdoc research scientist, he ran bulk-seq RNA for our patient's CD4 cells and healthy controls. And he found that TBX2, the TBAT, was also decreased in our patient population. And we confirmed with qPCR that patients had lower expression of TBX2. And also we did the flow cytometry, and TBAT was lower in patients. So this study shows that there is a reduction of CD4 T cell responsiveness is with additional Th1 response. And there is a Th1 master regulator. TBAT is low, and the downstream interferon gamma and chemokines were low. And it's really suggesting the broad alteration of development of Th1 cell response in 17q12 deletion syndrome. So why is it important? Because I think many of you already know that interferon gamma, recombinant interferon gamma, is already in the market, and it's being used to treat CGD patients. And it's shown that interferon gamma can really reduce the infection in CGD patients. So, looking at this data, I'm maybe like using recombinant interferon gamma in this patient population who have severe infection history, that might be helpful for them to reduce their infection history. So in summary, I think the first part I already went through, and the last part, I think I want to make a big emphasis that, we should not ignore VUS. I think we should work around the VUS. And these days, a lot of VUS are being delabeled. So I already, I have 2 mutations that were VUS, but we made them pathogenic based on the functional study and also based on our clinical presentation of the patients. So that's one important fact. And, I know the immune profiling, in-depth immune profiling is not easy, but that might be really the way we figure out more about our patients and be able to find some biomarkers that can show their disease progress, and also be able to come up with targeted therapy for these patients. Yeah, so I do want to acknowledge Dr. Kang, who has been my mentor since I joined Yale Allergy Immunology. I still work in his lab, and Hyunjun was the postdoc who helped with all the single-cell RNA-seq, and Reyes always helps with bioinformatics, and especially Samantha and Arlen, they've been working hard on these projects. And 17q12 Foundation has been my main connection about this syndrome, and they've been so helpful. And NIH always so helpful with all this functional study of variants that I find, and the rest of all the allergy immunology group at Yale for, just we are enjoying so much about seeing our patients, but it can be challenged, but we hope we can help our patients better. Thank you.
All right. Get a microphone. Okay. Dan. All right, great talk. Thank you very much. I think that's very exciting. We are now open to questions. There's 40 people or so on Zoom, so I guess the questions will come in to you, right, Debbie? So any questions from the audience? Yes, Sebastian.
Thank you. Simple one. Well, thanks so much for that presentation. But as you know, we see a lot of patients who have maybe a little bit of a low IgG. They may or may not have bronchiectasis or other airway manifestations. When should we consider sending them to you, and which kind of workup should we initiate beyond just measuring immunoglobulins? Should we get pneumococcal titers? Should we get other vaccine titers, diphtheria, and so forth? So what would you recommend to make it easy for you guys?
Great question. So it's very hard, right? When to draw the line. I guess like, if you have a patient that their immunoglobulins are not that low, but you are concerning about the patient. There is something wrong about, you know the patient the best at this situation right now. So if you are concerning about the patient and if there is nothing else you can do for the patient, and if this slightly low IgG is really the only thing that is abnormal for the patient, then I will probably go with checking subclasses. I think that you can easily do. Vaccine titer has been challenging. It's really hard to interpret sometimes, but if they respond to robust, that's great, then you don't have to worry. So you could do the vaccine challenge. Flow cytometry becomes a little more complicated. So, after vaccine challenge, if you still have suspicion for primary immune deficiency or some kind of immune defects, then we are happy to see the patients.
Other questions? Other questions? Any other? I have a question. So when you showed, I think that this is a big challenge for us, the referral piece, because we do see a lot of patients that have non-infectious manifestations or kind of quasi-infectious, where they have, but not like frank pneumonia, sinus disease, but where their bronchiectasis or their asthma is relatively severe, and we pick up a subclass deficiency, and it's not always clear to us when we really should be initiating a workup and what we can kind of work on, in our clinic, basically, or what really needs to be referred to you, because ultimately we often get the answer back that, well, the patient's doesn't really have a definable syndrome that we can get, approval to give the patient IVIG for or give IgG replacement. So, it's kind of like waiting for the patient to become very severe until we actually, initiate a therapy. So is there a way we can kind of move this forward, you think, or are we kind of stuck, with a lot of these patients?
No, I think bronchiectasis is definitely a sign of, primary immunodeficiency. I think we value bronchiectasis very highly on top of our list, whether we should really consider them as immune defects, having some kind of immune defect and having true pulmonary manifestations. So asthma is, we talked about it a lot. It's hard where to draw the line, but I think, you guys are the experts. You tried everything. You tried all the biologics and your patient is still not doing well. And there is a slightly low IgG subclass 2, I think those should need further evaluation. And I think now one of the first test we supposed to do according to Primary Immunodeficiency Society is genetic testing. They are like, don't even bother checking immunoglobulins, go with the genetic testing. Like they really value the genetic testing. So, but then the problem is most of the time we get VUS when we don't know what to do. But I think, better defining the genetic testing, better defining the VUS will be very helpful. But also, as you know, immune system is very complex. We are only checking probably total of 10 different labs here, right? We are probably missing a lot of pieces about the patient's immune system. So I don't think we can just go by what we are looking at, right? I think we have to look at the patient. If the labs are not matching the patient, I go with the patient. Like, I think we have to do everything to treat the patient.
All right, great. Okay, I think we have a couple questions on the chat. Yes.
Thanks for that talk. This is a question for our ILD patients, especially the ones with autoimmune disease where we're immunosuppressing them. Do you think that there are specific tests that we should always be checking before we start immunosuppression? Like, should we always check immunoglobulins and subclasses in those patients? Is there anything else that you would recommend?
I guess it depends which biologic you are using, right? So if it's rituximab, Yes, immunoglobulins. I don't think you need subclasses, probably just IgG, and what's the baseline B cell count, right, for the rituximab. But for T cell immune suppressive therapies, we haven't really seen big difference in the T cell numbers. But I think in general, if you know what you're targeting, having the baseline of the targeting cell profile will be helpful. But rituximab, yes, like always immunoglobulins and B cells.
So thank you. So just a related question. So I sometimes see patients who've already been started
Mhm,
on a drug that suppresses their immune system
Mm.
for Crohn's disease or
Mm.
multiple sclerosis or something like that. And when they get recurrent infections or bronchiectasis or
Mhm.
interstitial lung disease, I quickly blame it on the
Yeah,
treatment
yeah,
that they're already on.
Mhm,
But it didn't occur to me before your talk
mhm,
that maybe that's not the right
mhm.
not the right answer.
Yeah,
Like
yeah.
maybe because it's a critical question, because I may go back to the gastroenterologist or neurologist and ask the question of whether they can stay on this medication,
Mhm.
but maybe the medication isn't the problem. Maybe it's something else. Any thoughts on that?
Yeah, yeah, that's always the problem. But so for that, we might not find the answer, but genetic testing, right? So if there is a high suspicion for PID, genetic testing might give us idea whether the patient had a primary immune defect before getting onto all these medications or not. But sometimes after stopping the immunosuppressive therapy and seeing how their numbers comes back can be helpful, but sometimes they never go back to where they are. A lot of times, especially rituximab, their B cell count, their speech to memory B cell count, they never really go back to where they are, even though their immunoglobulins might be fine. So it's hard. But right now, the only thing we can do is genetic testing to see whether they have underlying primary immune defects.
Let me go to the online questions. So Murdu Gulati asks, can you talk a little bit about your experience with GLILD and your treatment approach? So granulomatous
Yeah, yeah.
lymphocytic
So,
interstitial lung
uh-huh.
disease.
So we have few patients with GRILD, and I'm sure all of these patients are being seen by one of you here. So I think we usually monitor them, and soluble IL-2 receptor has been a great marker. Dr. Christina Price has been following many of these patients, and she used soluble IL-2 receptor as the marker for progression of the lung disease. And rituximab has been pretty successful on us for our patients, and they're gonna be on IVIG. So I think using rituximab is really just, I guess if we have to use immunosuppressive therapy, we do use it for immunodeficient patients as well, because it's more important to control their non-infectious manifestations, because that's what's gonna push them to their higher mortality. So rituximab has been the first line therapy for GRILD patients.
Wow. So a couple more questions. Norwalk PCCM has asked, in the absence of recurrent pulmonary infections, would you recommend testing patients with ILD asthma for immunodeficiency? If so, when? In other words, I mean, yeah, you don't have to answer that question.
Yeah, it's hard.
No,
I think it's hard. I mean, I think how complex it is, right? If
Right.
it's a ILD asthma that you can manage, I always feel like if you can manage these patients with what's available, I think then we don't have to push too hard, right?
Right.
But when we hit at the point where we can manage these patients,
Yeah,
then that's when we think about anything on the book, right?
right.
And I think at that point, PID can be the first thing you can think of.
I think
Yeah.
that's kind of our approach.
Yeah,
The
yeah.
severe asthmatics who
Mhm,
come our way,
mhm.
that's when we
Mhm.
really are looking
Mhm.
because we feel like we need something else, that there's something we're missing.
Yeah. And also sometimes the biopsies are helpful. I think lung biopsy and GI biopsy, all of them, like a lot of times patient doesn't complain anything, but if you have no plasma cells, or if you have like way too high like T cells, or like, some some dysregulation you see on the biopsy can be a sign for PID.
So that I'm going to ask one question before Finbar's question, but in your VUS studies, you showed that there are these kind of clusters of patients that fall, and not a huge data set, but they still looks like there's clusters of immune abnormalities. But it looked like most of those patients, like somewhere around 50% or higher, were identified as IgG deficient.
Yeah.
And were receiving, many of them, IgG replacement therapy. But what about the patients that didn't have IgG deficiency? In other words, did you define a subgroup of one of those clusters to be the predominant cluster associated with patients who had normal IgG levels, but a clinical manifestation of immunodeficiency?
That's definitely possible, but we didn't do that because the process we did it was we crossed them based on their gene function first, and then associated with their clinical manifestations. But that's a really great idea. Maybe we should.
Which
do
are the
that.
ones that would have normal testing?
Definitely. Yeah,
right?
yeah.
Because maybe one of those, T cell cluster or whatever is more predominant.
Great, thank you.
So
Yeah.
Finbar asked the question, I think our typical immune deficiency workup in pulmonary for patients with bronchiectasis, other chronic airway issues, not otherwise specified ILD, organizing pneumonia, includes IgGs, total IgGs with subclasses and antibody titers. When should we be looking at complement levels, disorders of phagocytosis, et cetera? I don't see those typically being checked in our referrals.
Oh, so what we do is we go based on the box and what kind of infection they get, right? So I think in right here. So so there is encapsulated organism infection and immunoglobulins are normal, then we check complements. And then if there is necrotizing pneumonia or lung abscess or skin abscess, some kind of abscess, we do DHR. So based on what kind of infection they have, we do often check complements and phagocytic disorders.
Okay. All right. Any other questions? All right. Well, thank you for an incredibly educational
Thank
talk.
you.